In this lecture, I will be talking on allergic rhinitis. Allergic rhinitis is the most common atopic disorder. It is known as hay fever. Allergic rhinitis results from the reaction of airborne allergens with sensitized muscles in the conjunctiva and nasal mucosa. And now I will be talking on pathophysiology of allergic rhinitis. As can be seen here, these are the mucosal surface dendritic cells. They take the allergen or the antigen or the airborne allergen, internalize it and process it and present it them to T helper number 2, and this will T helper number 2 will get activated and produce cytokines. For example, interleukin number 3, it acts on basophils and maybe muscle, and interleukin number 5, it acts on eosinophils and lead to eosinophils proliferation, and interleukin number 4, and this is very important for the class switch to IgE antibodies. So allergic rhinitis is characterized by early and late stage responses. In early reaction, the muscle get activated and they produce histamine, prostaglandin, and leukotrienes, and this will lead to sneezing and rhinorrhea, and this appears in 30 minutes. Late stage, which is nasal obstruction, occurs 6 hours following exposure. So eosinophils chemotaxis is responsible for this stage. Allergic rhinitis classified into actually into two items or categories, and this depends or according to duration, into intermittent, where symptoms persist less than 4 days per week or less than 4 consecutive weeks. Or it could be persistent allergic rhinitis as symptoms that are present more than 4 days per week and for more than 4 consecutive weeks. Also, allergic rhinitis classified according to symptoms into mild, when patient has no impaired sleep and is able to perform normal activities, and classified into moderate to severe allergic rhinitis when interferes with the sleep and daily activities of the patient. So diagnosis: skin prick test, and this is to place a drop of allergen on forearm or back and prick it in 15 to 20 minutes. Wheals and flares will occur if the test is positive, and also blood tests may help in determining the specific IgE antibodies by running a test known as radioallergosorbent test or RAST. Treatment of allergic rhinitis: this include nasal saline irrigation, oral antihistamine, intranasal corticosteroids, combination intranasal corticosteroid antihistamine sprays, leukotriene receptors antagonist, immunotherapy. Immunotherapy uh, to allergic disease in general, or to allergic rhinitis, it is known as hyposensitization, by giving just gradually increasing doses of allergen to which the patient is allergic. So repeated subcutaneous injection of allergens lead to shift uh, towards IgG production, or to shift from T helper 2 to T helper 1 with turning off the IgE response. And IgE antibodies, they bind to allergen, forms a complex that removed by phagocytosis. Monoclonal anti-IgE also uh, will bind to free IgE antibodies. So these monoclonal antibodies, when given to treat allergic rhinitis or monoclonal anti-IgE, they just couple or bind to free IgE antibodies, and not to membrane and not to bound IgE. As can be seen here, IgE is specific for some allergens. They bind to Fc epsilon R1, which is high affinity receptor on the surface of the muscle. And despite that, subcutaneous immunotherapy is well established, but however, the risk of anaphylaxis has led to the development of other administration routes. For example, oral, sublingual, or nasal uh, route to avoid anaphylaxis. Thank you very much, Professor Ahmed Bolan.